Thank you. So today we're going to sort of rush through mental health and PKU. We are going to talk a lot about sort of the basics of PKU, just because I feel like you can't really grasp how PKU impacts mental health without understanding sort of the basics of the disorder. So PKU is phenylketonuria. It's an autosomal recessive disorder. So if you think back to biochemistry, if both, not biochemistry, biology in high school, if you have two parents who are carriers, there's a 25% chance the child will be affected by the disorder, 50% chance they'll be a carrier, and then a 25% chance they'll be non-affected and not a carrier. It is a deficiency of phenylalanine hydroxylase, or PAH. Typically in the biochemical pathway, which you can see up there, phenylalanine is converted phenylalanine hydroxylase converts phenylalanine to tyrosine. And so that's significant because phenylalanine in concentrations greater than 6 milligrams per deciliter or 360 micromoles is neurotoxic. It also impacts production of dopamine, serotonin, other physiological processes that require tyrosine, because in classic PKU that is untreated, Phe levels increase and tyrosine levels decrease. Without treatment, because Phe is neurotoxic, we see significant intellectual disabilities and neuropsychiatric concerns. So we used to call this profound mental retardation, which is not the politically correct new terminology, and so we typically refer to mental retardation now as intellectual disabilities. PKU occurs in about 1 in 10 to 15,000 individuals. In Alabama, we have around 60,000 births every year, and so we typically see 3 to 4 new diagnoses of just PKU every year, but we have seen up to 7 in a year. Sort of just depends on, it just varies by year. Again, an average of 3 new diagnoses. So the history of PKU, I actually didn't know all of these dates until I started working on these slides. In 1934, PKU was first described by a Norwegian physician looking at patients with sort of unexplained intellectual disabilities. But it wasn't until the 1950s that a treatment plan was developed that seemed to be effective. So at that point, they treated patients with PKU with a low phenylalanine diet. Actually, they treated patients with a no phenylalanine diet, which now we know is significant because phenylalanine is an essential amino acid. So eliminating it completely from the diet is not, it's an effective treatment, but it doesn't promote normal growth and development. In the 1960s, newborn screening was developed and became widely used in the US and Europe. And then in the early 2000s, sort of treatment, between 1950 and 2000, treatment evolved and changed. And we have, as a result, we have several different, very different groups within our patient population that they're pretty easy to identify, and we'll talk about those some. But initially, somewhere around the 1950s when PKU was first treated, the medical community thought that brain development was complete at age 6, and therefore neurotoxins could not cause negative consequences. And then eventually the medical community said, oh no, that's age 10. And then it was, no, age 15. And now it's a neurotoxic can negatively impact executive functioning and other aspects of life at any point during the lifespan. So now we recommend diet for life. And so that's why we see pretty significant differences in different patient populations. So our patients who were diagnosed basically, and these are general time frames, but our patients who were diagnosed after 2000 or in the early 2000s, they were told diet for life would be their treatment from day one, from when we first met their families, and they were never given any indication or idea that they could go off what we call off diet without negative consequences. And so those are our patients who have really the best outcomes. Some of them are just now becoming young adults, going to college, having their own families. But those patients who were told they could go off diet at age 6 are very different intellectually because they were impacted by neurotoxins, elevated Phe levels as a neurotoxin. And so those patients as adults tend to have a really hard time working, keeping a job, maintaining insurance, which in turn impacts their treatment and whether they're able to have the formulas and medications that they need to be on diet. But I'm getting ahead of myself. So to diagnose newborn PKU, patients are identified with newborn screening. Currently, we screen for 35 disorders. Prior to 2004, we only screened for 5 disorders. PKU is one of them. But this is a newborn screening card. So before a baby goes home from the hospital, sometime usually in the middle of the night, a lab tech will do a heel stick, and from that heel stick, they will get 5 hopefully really good circles of blood on a filter paper, which goes to our state lab. And usually around days 9 to 11 of age, the earlier the better, we would get an abnormal result. So this is not necessarily a diagnostic test, but it is just a screening. So based on an abnormal screen, we would see a patient immediately. So if our newborn screening coordinator gets a result at noon on a Friday, then we call the family at noon on Friday and say, you've got to come to Birmingham. And that's whether they live in Birmingham or Mobile or Huntsville or anywhere in the state. And then we do confirmatory testing. So that might, for PKU, is lab work. So and typically we can have that result within, say, 8 to 10 hours. So we know we can confirm that diagnosis. And that's called a plasma amino acid profile. So we look at all of the amino acids in the plasma and specifically assess phenylalanine and tyrosine. We also look at blood and urine biopterin. We don't currently have any positive blood or urine biopterin patients. It essentially changes the way we treat PKU. It's a less treatable form of PKU. So we'll be focusing on the biopterin negative PKU patients today. So we get a newborn screen. From that, we get some sort of indication that we have a patient with PKU. We confirm testing. So hopefully before the baby is 2 weeks old, we have identified them. We've implemented diet and treatment, and they're in good, what we call in good control. And so to monitor that for infants, we checked weekly Phe and tyrosine levels, and that's from a heel stick that the families can do at home or the pediatrician can do from their office. And then anybody over a year of age that we consider in good control that's not making any significant diet or treatment changes, we would require levels every other week. We also do repeat plasma amino acid profiles anytime we have concerns about growth, overall nutrition, health in general. We repeat them generally in older patients at least annually, just so we can make sure we're not missing anything. But typically we look at those for low values of specific plasma amino acids or high Phe levels to make sure we're meeting the patient's protein needs. So our treatment goals and strategies for PKU are really not that different from the general population. So we achieve that in a very different way, but normal growth and development for a patient with PKU is the same as any other infant. We're just trying to achieve the same growth and development with the same macronutrient and micronutrient goals, but we have to reduce significantly one specific amino acid, which can be quite a challenge. So our goal is to maintain Phe levels above 2 milligrams per deciliter because below 2, we know that babies don't typically grow very well. And then, again, Phe is an essential amino acid, which is why it can't be eliminated from the diet. And then we want to maintain plasma concentrations less than 6 milligrams per deciliter to prevent brain damage, basically, because again, Phe is neurotoxic. We initiate treatment as soon as possible. The earlier the better. And PKU is one of the only disorders that can be treated 100% with nutrition therapy. So that's a really interesting part of my job, because if I saw a patient in the hospital that had hypertension or high cholesterol, there are different reasons for those labs to be elevated, and there are different ways to treat them. They can be treated with diet, depending on the patient and what the situation is. It might or might not be the best treatment for that patient, but there are a lot of physicians who would say, oh, we'll just put you on medication and we can take care of that. Don't worry about diet. Hopefully they combine medication with an improved diet. But we all know that requires a dietitian. It usually requires a patient to have a lot of help, which they may or may not, patients may or may not have access to a dietitian on a regular basis. And that's one really nice thing about our clinic is our patients can call us anytime. They have our direct numbers, and we talk to them regularly about diet and lab results and formula, which I know I keep mentioning formula, and we're going to get to that. But again, PKU is one of the only diagnoses that can be effectively treated 100% just with nutrition therapy. So the nutrition therapy in PKU is you get whole protein, which is the protein you would eat from any food, the protein you would get from eggs, dairy products, meats. You get a small amount of phenylalanine from those products, and we ask our patients to count milligrams of Phe because it is much more accurate than looking at how much protein they consume, because the phenylalanine content can vary greatly from one product with 1 gram of protein per serving to another product with 1 gram of protein per serving. Similar to other amino acids, and that's where we get into complementary proteins and things like that, which is a whole different talk. Typically with infants, the Abbott protocol, which again we'll talk about, recommends initiating treatment at 20 to 70 milligrams of Phe per kilo of body weight. And so we do, that's really a wide range. And so we find in our clinic that the majority of patients, we start based on how high their levels are when we see them for the first time on that amino acid profile at 45 to 55 milligrams of Phe per kilo. We get that from breast milk or standard infant formula. So usually it used to be Similac because WIC had the Abbott contract. Now it's usually Enfamil for the same reason. So these products typically contain all of the amino acids, they're whole proteins, and we can get that specific amino acid information directly from the manufacturers. So we know exactly how much Phe is in a standard infant formula. We have a pretty good estimate of how much Phe is in breast milk. And so we encourage moms of babies with PKU to either continue breastfeeding or to express their milk. But we often find that they choose to use a more standard formula for a variety of reasons. So that typically meets only maybe 10 to 20% of this new baby's protein needs, and it's the same for an adult. It's just not standard formula or breast milk. It would be protein from breads and pastas, things like that. Medical food or formula is where we get the rest of the protein, so this is what we call protein equivalent. So this is basically an elemental formula. It's composed of free amino acids, all of the free amino acids except for phenylalanine, and usually is fairly high in tyrosine to help that physiological process pick up and that biochemical pathway pick up and keep going. And these products, so I say here available by prescription only. You can't get them in the store. You can't get them from Abbott or Mead Johnson or whatever the formula company is without a prescription, but insurance does not recognize them as typically does not recognize them as prescription products. So that is a huge financial concern for our families. And then, of course, for patients who are not on infant formula or breast milk, then they make up that whole protein portion of their diet with what we call a low protein diet or a low phi diet, which is extremely high in fruits, non-starchy vegetables, and free foods. So these are things like sugar candies, not peanut butter, peppermint, Jolly Ranchers, Pixie Sticks, like things we don't ever recommend as dietitians. Those are free foods, things that our kids can snack on all the time without worrying about phi intake. It includes a limited amounts of bread, rice, pasta, starchy foods basically. These can be included in small amounts, but a 1 ounce bag of Lay's potato chips has around 50 to 75 milligrams of phi. And so for a toddler, usually their prescription would be around 250 or 300 of phi a day. And for an adult, it would be like 400 or 450. So if just to put in perspective, if 1 ounce of plain potato chips really it does make up a significant portion of their protein intake from sort of regular foods for the day, that significantly impacts what they're able to eat in terms of starchy foods, like pasta, especially when you consider that if you go to a restaurant and you order a pasta dish, maybe a veggie pasta like we had yesterday, that there's no meat, there aren't really any high protein food items included in that, but it would be extremely high in phi for a patient with PKU. And they'd only be able to work in maybe a half a cup of pasta, if that, if they planned really carefully the rest of the day. So foods that are not allowed at all are meat, fish, poultry, dairy, eggs, legumes, and that is quite a challenge for a lot of patients. Technically, you could work in like 1 ounce of meat or 1 bite of meat for most people into the diet. The problem is, why would you tell somebody they could eat 1 ounce of meat and nothing else for the rest of the day? So they can eat it's similar. It's a similar concept to calories. So I could eat gallons of non-starchy fruits and vegetables for the same calories that I could eat, a very small amount of meat or 1 egg. And so it's not really a good trade-off. And so that's a challenge we run into with a lot of families. So mental health challenges in treated PKU. So it's important to remember, prior to effective treatment in the 50s, 60s, 70s of PKU, majority of patients experience significant, profound intellectual disabilities, and were not able, most of these individuals lived in group homes because behavior and cognitive abilities were really limited. We actually have one patient who's in clinic. She's been off diet for a while, and she just called the other day. She's set a new level. Her result was 6.6, which is really great considering she's been off diet for a while. But she's in her 60s, and her brother, I'm not sure if she was diagnosed by newborn screening or not, or if her brother had already been diagnosed. But her brother was diagnosed well before newborn screening, before effective treatment for PKU, and he has lived most of his life in a group home and has a significant intellectual disability. She was in that group of patients that was told initially she could go off diet at age 6. And so just hearing her talk about the differences between her and her brother and the things that she's sort of been through in terms of PKU and what is treatment and what is diet, and what her goals are really interesting, because she and her brother are only a couple of years apart in age, but the fact that she was diagnosed and treated early and he was not has made a huge difference for them. So that's untreated PKU. In patients with well-treated PKU, so we're talking about patients who have had levels between 2 and 6, essentially their entire lives since maybe 8 or 10 days of age, can experience difficulty with focus, attention. A lot of our patients get ADD or ADHD diagnoses. Even patients with good levels typically here and there have a high level based on something they ate that they weren't quite sure how much Phi was in it, or we've had patients go on school trips where their parents were told they were getting ices, but they actually got smoothies, which makes a huge difference because an icy is basically a free food. A smoothie with yogurt or bananas even would be really high in Phi. So we know that any exposure to an elevated Phi level can negatively impact any of these. So focus, inattention, ADD, ADHD, memory, depression, particularly in patients who have higher levels or were in really good control at one point and are no longer in good control. Adults, depression, anxiety, relationships. So almost all of our adults who are married or have a significant other, their significant others almost always tell us they can tell a huge difference when the levels are good because their partner is not as moody or doesn't snap at them or is just happier and in a better mood all the time. And then career potential. So this makes a huge difference because our kids who our young adults are, our patients who are just now becoming young adults are the ones who have the most potential to go to college just like their peers, to have good grades, get a good job, have insurance like their peers. Everybody's always, all of our patients have always had those opportunities, but in the early days, with significant intellectual disabilities, and being quite a few years ago, they didn't have as many opportunities as our patients do now. So mental health challenges impacting the families of the PKU patient. So the most profound time that I noticed the most significant impact on the family is at diagnosis. So I can tell you my personal experience was I knew about newborn screening, and when my oldest daughter was born, if you don't have children, when you do have your first baby, you probably haven't slept, you've either had a C-section or you've been through basically a traumatic experience. You don't know what's happening. Everybody under the sun has an opinion and wants to tell you what you ought to do, how you ought to feed your new baby, how you ought to change their diaper. Everybody has an opinion about everything. And so you go home with this baby, this healthy, perfect baby who doesn't sleep, who cries all the time, and you feed them. You either are trying to breastfeed or you feed them formula. And I think most new moms sort of struggle to just kind of get through those first couple of weeks, and then they don't even know that the hospital did this newborn screen. So back to my experience, when my oldest daughter was about 18, 20, 24 hours of age, I said to this nurse, I want to see that card when y'all do it because I want to be sure it's a good sample. Like I want to know that all 5 circles were filled up so you can screen for all the disorders, and if there's something wrong, I'm not going to have to wait an extra 2 weeks or 3 weeks to find out. And this cranky old nurse said, well, honey, you're going to have to walk down to the nursery at like 4 o'clock in the morning. And it was just too much. I could not do it. I was too tired. And I was lucky that our screen was normal. Everything was negative. But then after that, you take home your new baby and you think after a week or so, you think you're kind of adjusting to life, kind of figuring this new mom thing out. And you get a phone call from somebody you've never met that says your baby had this lab work done in the hospital before you left the hospital, and it came back positive for phenylketonuria, and the majority of our families have never heard of that, and the first thing they do is Google it because their pediatrician doesn't know anything about it either. And so they have to, pack up their baby and their diaper bag and all of their pump and formula and all this stuff, and come to see us in our office and take their baby to the lab again for a pretty significant blood draw. And so we spend, an hour, 2 hours with them talking about, learning to use a gram scale to measure formula, how they're going to mix formula from now on, because they have to decide, I'm sure they feel like they have to decide on the spot whether they're going to use breast milk, continue breastfeeding, switch to formula. Some of these babies already have reflux issues or constipation issues we deal with, and so they ask us all of these questions, but we're talking to them about using a little bit of breast milk or breastfeeding a couple of times a day, and we're talking about using a new formula they've never heard of, and we're telling them that they have to get it from WIC, they can't buy it in the store, or they have to get it through a home health company. That the home health company will ship it to them, and they have to pay this fee, and usually we try not to hit them with, your child's never going to eat meat. Your child will have to drink this special formula his whole life. We usually try to save that for the second appointment, but if they ask, we tell them. And so I would say the majority of new moms cry, and it is just a horrible experience for them, and we make it as painless as possible, but the basis of the appointment is they're getting bad news. Usually it doesn't take them too long to figure out it's gonna be okay, but that first appointment is usually pretty awful. So that is the biggest mental health impact I see on a regular basis. The other piece of that is, you have to be fairly intelligent and organized to keep up with 2 or 3 special formulas for your baby, and whether you're mixing it the same way every day, and how much they're taking. And I need to call my dietitian, but I really need to call her between the hours of 8 and 2 if I'm going to get a change mate today, because my baby she wrote the prescription, she wrote my recipe for 20 ounces, but I really need 22 ounces. Or my baby's been sick and she wrote the prescription for 20 ounces, but he's only taken 16. So to get a new short-term recipe or a new long-term recipe, or taking the baby to the pediatrician to get more labs done, can be quite overwhelming. So as these kiddos get older, their families tend to adjust and sort of figure out that it's going to be okay. And they are. We expect a patient with PKU to be very typical, just like any other child or adult, if they maintain levels between 2 and 6 for their lifetimes. But travel is really difficult, so families call us and ask for letters because it's hard to take a can of white powder on a plane or into a football game or wherever they're going. So travel is difficult if they're traveling. We have some patients who are not from the U.S., and so if they go to Spain or the Middle East or wherever their families are to visit, sometimes they stay several months at a time. Well, they have to pack a significant supply of formula to last them that period of time, because they may not have access to it while they're out of the country. So young children, school is difficult for a lot of families, particularly school lunch. We tell everybody in a public school, the school is required to provide an appropriate meal. They're not required to provide something your child likes. So if they have carrots on the menu that day and carrots are appropriate for your child's probably going to get carrots. But if your child refuses to eat them, then your child may not actually eat that day. We also find that there are requirements of the school nutrition programs, like the requirements for reimbursable meals, that often create a lot of conflict and misunderstanding among the cafeteria staff, the parents, and to be honest, reimbursable meals and child nutrition is not my specialty. So a lot of times I have to just sort of ask the school cafeteria manager, what can you do, or what is the challenge here? A lot of schools really try, but without really understanding the basis of the disorder. And I can see where it would be frustrating for them to have parents complaining about what they prepare because it's something their child doesn't like. But outside of that, we do get a lot of schools that'll just say, we'll give them a salad every day, and that salad ends up being lettuce and Italian dressing, because lettuce is low in Phe, and Italian dressing is vinegar and oil, so there's no protein, and that's appropriate for them. But then those kids get really tired of lettuce and dressing, and it's not really what I would consider an appropriate meal, because I know in school nutrition they always have some sort of fresh fruits. They always have some sort of canned vegetables that are appropriate, but I've even found that sometimes they're not going to open a number 10 can for one serving of green beans or whatever. So there are challenges, and the majority of our families do choose to send their kids lunch, but some will look at the menu and just let their child buy lunch on days when they're having enough foods that they can eat, or their kids will eat off the salad bar, and then that's a lot of trust for a first or second grader. So curiosity regarding forbidden foods is not the greatest term, but it makes the point here. Typically meats. We all know kids trade food, and some of our kids are really good about asking their parents can I eat that, or their teachers who may or may not really understand. But I would say the majority of our school-age kids are curious, and sometimes will tell their parents after the fact, hey, I ate a hot dog, or I wanted to try bacon or something like that. So those are challenges. Sports are also difficult because most of our kids don't really like to take their formula with them. So there are a couple of issues there around their formula. One is it's always expensive, which is, of course, a mental health concern for the families. But the formulas are elemental, which means they smell and taste quite different than what most children are accustomed to. And so they have to be mixed. So the most cost-effective options are powders. So it comes in a 400-gram container, and so it has to be mixed. It has to be refrigerated. It has to be, consumed within a certain period of time if it's going to be out, like at soccer practice or something like that. So most of our kids choose not to take their foods to school or for sporting events, and which their formula is a significant source of their calories, and so they tend to get hungry. And you don't see a lot of first or second graders snacking on an apple or strawberries when their friends are eating chips or protein bars or things like that. So adolescents, friend groups become a challenge, eating out without parents being present. Most fast food restaurants have options, but they're usually very limited. So like Chick-fil-A has a side salad with no cheese on it. They used to have coleslaw, they don't anymore. Their kale salad is a pretty good option, but it has raisins and some other things that are higher in protein. Their French fries. So most fast food places, French fries are sort of the choice, the preference, but a large fry at any fast food restaurant is well over any patient's fee prescription for the day. So it makes eating out quite difficult. So preparing meals, we recommend. Most of our families use special low protein foods, which are quite expensive. So just to put it in perspective, baking mix and pasta are the most popular products. They're the most cost-effective products, and they're the most versatile. So that's what we recommend to our families. But a box of baking mix, which would be similar to Bisquick. So $2 or $3 for Bisquick, 10 to 15 or more for low protein baking mix. And then pastas are the same. So like a pound of pasta would be 99 cents for typical products, and they're more like $8 or $10 a box for low protein products. So parents do a lot of prep with foods, and they also tell us they don't reheat very well. College is a challenge because then you have to learn to cook in a dorm room when maybe you only have a microwave. Again, driving. So if your fee levels are 16 or 20, which is not totally uncommon for a rebellious teenager, do you really want them driving? If you know they're not making good decisions because their fee levels are high, do you really want to meet them on the street? Because I don't. So we typically recommend that teenagers with elevated levels not drive, but I'll say that doesn't always happen. And then of course work. So we have one teenager, she graduated from high school, took a year off to work, and she was working at Jack's, so she ate French fries every day, sometimes 2 meals a day, and her levels are terrible. But she drives, she's pretty much financially independent. So her mother says, well, I have no control over what she eats or what she buys to eat while she's not at home, which has been a huge challenge. So adults, again, relationships, mood, cooking, again, it's amazing how many people don't know how to cook or don't have time to cook. Not having time to cook is not amazing, but it's a pretty typical problem. Maternal PKU, I think I have a whole slide on maternal PKU, but in short, the developing brain during pregnancy is at higher risk with exposure to elevated Phe levels than any other point in the lifespan. So those very early days of pregnancy, often before a patient knows she's pregnant, it's essential to have Phe levels between 2 and 6. Some clinics even recommend levels between 2 and 4, which is insanely difficult to achieve. But babies, therefore we recommend levels between 2 and 6, 6 to 12 weeks prior to conception, which requires a lot of family planning. But these babies are at risk for microcephaly, which is basically the baby's brain didn't grow, and his brain is small, heart defects, and intellectual disabilities at birth. And then of course another mental health challenge is the cost of therapy, because depending on what your formula is, I think most recently I priced Phoenix 2, which is one of the most common, most cost-effective formulas. And it's around $300 for a case of 6 cans, and that is available at a 10% discount if you buy it out of pocket. You don't go through your insurance on the front end. And that would last most of us in this room a week, 2 weeks maybe. So to think through that cost and fighting with insurance to get them to cover the products, particularly if your child decides they don't like one of the more cost-effective products and they want a ready-to-feed or more convenient product, the cost just goes up exponentially. So maternal PKU, I think we talked about this. Preconceptual planning and early prenatal care are really essential. We had one baby with a heart defect that died. We've had quite a few with that were microcephalic and basically didn't live normal lives because their brains were damaged before they were born, and that is 100% preventable. So a woman with Phe levels between 2 and 6, 6 weeks prior to conception and during the entire pregnancy, her pregnancy carries the same risk as any other pregnancy. So her baby has the best chance to be just as normal as any other baby, even though she has PKU. Okay, so this is newer therapy for PKU. There are 2 medications that are available now. As I said in the beginning, PKU can be treated 100% with nutrition therapy. In 2007, Kuvan came out, which is a cofactor to phenylalanine hydroxylase. So theoretically, if you are a responder to this drug, it has the ability to sort of boost your enzyme activity and lower your Phe levels. The question is, at $420 a day for an average adult, is it really worth taking this drug so you can eat more potato chips or potatoes or corn or bread or pasta? The newest drug that's available, so Kuvan is a powder that you dissolve in liquid and you drink it. Palynziq is a daily injection. It is substitution therapy, enzyme substitution therapy. A daily injection with a 6-month titration schedule. So once you start it, you don't get to your max dose for 6 months. The benefits are potentially astronomical. So our patients We have one patient who recently started Palynziq. His Phe levels were between 20 and 30 before Palynziq, and once it started working, they dropped to 0. And so he eats basically a regular diet, has not been on a low protein, low Phe diet with formula for quite some time. It is also very expensive, and the risks are pretty significant. So 88% of patients in the clinical trials experienced injection site reactions, so like heat, redness, swelling at the injection site, joint pain, headache, skin reactions, itching, nausea, GI discomfort, vomiting, cough, diarrhea, fatigue, I may have already said that, and up to anaphylaxis, so which is obviously a pretty significant side effect. Our patients who take Palynziq pre-medicate with Zantac and an antihistamine, Zantac and a reflux med. Sorry, I can't remember which ones specifically we recommend, but they also have to have an EpiPen before they even get their injections. And so Palynziq has the greatest potential. Kuvan is FDA approved 4 years and older. Palynziq is FDA approved 18 years and older. So we have quite a few 16, 17-year-olds who are really interested in this. They just haven't started yet because they can't. But those are the only 2 medications other than formulas that are available to treat PKU. And then these are some really fabulous resources. So if you ever run into a PKU patient or another patient with an inherited disorder of metabolism, the Abbott Nutrition Support Protocols, which you can get a PDF of by calling this phone number, the metabolic hotline, describes, there are like 30 or 40 chapters in this book. Each chapter is on a different diagnosis in it. So it explains the biochemistry, it shows you the pathway, and it gives you examples of diet prescriptions and growth and development targets, goals for lab values, sample diets, formula prescriptions. It's really a fabulous resource. GMDI, so Genetic Metabolic Dietitians International, is actually a fairly new group, and that's their website. On their website, under the resources tab, they have MNT protocols. So very specific. So if you have a patient with PKU with a level of 6 to 10, how much Phe per kilo you give them and how much protein from formula you give them, how many calories they need, what labs you need to check. Genetics Home Reference is a really good, quick and dirty, I'm in clinic, what the heck do I do with this patient? So it'll give you just a page or two you can read and get an idea of where you're headed and a little bit of basic information on a diagnosis. The American College of Medical Genetics has this link specifically is to their treatment guidelines for PKU, which is a really great reference, and it's what we use for most of our insurance appeals for patients who are trying to get formula. MetEd is a class that has some educational materials for the professional as well as for the patient, and that is their website. But it was developed by 2 metabolic dietitians, one in Denver and one in Boston, who have sort of made it their mission to educate metabolic dietitians and make sure people know what to do with these patients. And then your local genetics clinic. So is anybody from out of state? Okay, so if you're in another state, in our clinic, Susie Gertz, who you heard speak yesterday, and I are the clinic dietitians for Metabolic Clinic. In Alabama, you can reach out to us. If you've got one of our patients, we can tell you what their last clinic recommendations were. How much protein, how much formula, other goals that we set. But for other states, we're not going to know those patients. So, but your genetics clinic, usually associated with a children's hospital or genetics department at your medical school, will have a clinic where somebody can either tell you where to get started or something about your patient. And And so those are your best resources if you ever have a patient with PKU or another inherited disorder of metabolism in clinic. You guys have any questions? And Harriet, who you heard speak, was our sort of Alabama nutrition and metabolic disorders pioneer, right? Who took care of a lot of these patients when treatment was first initiated, right? So does anybody have any questions? Or Harriet or Susie, y'all want to add anything?
32 years.
Okay, Jenny?
I saw that the patients, they have a lot of changes in their lives. Could you treat also the family? There is a family group that they can like help each other to understand what is going on with the patient.
Yeah, so are you asking, like, do we explain what's happening to the family? Yeah, so a big part of our job is to help the families understand to help the families understand the disorder. Most of these families have no background in nutrition or biochemistry, and honestly, we struggle with some of them just to get them to feed baby foods at the right time, or to feed their child, appropriate amounts of formula at the right times. So we do work with them to try to educate them and help them make informed decisions on the weekends when we're not available, or something, times when they need to make a quick decision. And sometimes that's effective and sometimes it's not. But the nice thing about PKU is there are no emergencies. So with some of our other disorders, patients are at very high risk for metabolic stroke. With PKU, they're not. Just their brains that are at risk. But they're not any emergencies. So in most cases, especially for patients who have been in really good control, we can sort of fix it after the fact and get their levels down pretty quickly, and get them back on track. Does that answer your question?
Yeah, thank you.
Anything else? All right, thank you guys.